Agreed. Yeah, no, I completely agree, which is why at their core, both of these blood tests, although yes, it's Friday afternoon and we love talking about the science behind it and the biomarkers and the artificial intelligence that was used to create the algorithms, etc. At their core, both of these blood tests are telling us something that we deal with every single day in the office, right? And when a patient comes to me in the office and says, I'm worried that my father died of a heart attack at age 50 and I'm 65 years old, and I'm worried about my cardiovascular risk factors. My LDL is 90. Should it be lower? My blood glucose is fine, but my A1C is 5.7. Should it be lower? Those are patients that are very common in our practice because, among concierge physicians, among folks like myself who have a very concierge-like practice at the IMGH Heart Center, we have patients that are very well informed. They know where to find information about lowering their risk factors. But the question is that good enough? Are we delivering the kind of care that our patients, the individual patients sitting in front of us, should be receiving? We know that getting LDL under 100 is good. We also know that getting LDL under 70 for high-risk patients is better. We also know that in the Improve It study, getting LDLs under 50 for the highest risk patients, the really highest risk patients, is even better. We also know it's safe. We know that therapies like GLP-1 receptor agonists reduce atherothrombotic complications, even in people without diabetes. So ultimately, when it comes to our patient who's sitting in front of us, who is concerned about their individual picture, that's where tests like this can be really useful. Because at their core, it's kind of boring, right? I mean, one test tells you got coronary disease, one test tells you have a risk for an atherothrombotic complication. Simple answer. There's not a lot of nuance to the results that these tests tell us. But in and of itself, those results give us very actionable information. And no, my friends, in the medical world, we do not all lower our patients to LDLs under 50. We do not have all our patients at blood pressures of 130/80. The simple truth is a lot of our patients are resistant to that kind of aggressive treatment, but if given a reason to accept it, many more would be expected to accept it.
Amen. And that goes along with... Good morning, Docpreneur Nation. My name is Michael Tatro, and this is the Concierge Medicine Forum. This is a special edition of not only the Concierge Medicine Forum speaking and faculty edition, but also for the Docpreneur Leadership Podcast. We're going to release it over there. We have as a special guest today, Dr. James Januzzi. And Dr. Januzzi his resume is pretty impressive. We're going to go over his personal background here in just a second to just tell us a little bit about his personal story about why did you become a doctor? Because we always love to hear those stories from physicians. But today he's going to be talking about transforming cardiac diagnostics with machine learning and multiple blood tests and multiple blood proteins. That I know our physicians, our listeners, if you want to watch this will be available at Concierge Medicine Today.org, as well as the 4doctorsforum.org. We'll put it out there as well so you can see this presentation in case you're listening to the audio version. But Dr. Januzzi, thank you for being with us.
Hey, thanks, Michael. It's great to be here. Glad to join you.
Well, we're so glad that you're a speaker this year here at the Concierge Medicine Forum, and we're able to do this live with you. But before we begin, and you can go ahead and pull up your slides here in about maybe 30 or 45 seconds, but tell us a little bit about what inspired you to be a doctor.
Oh, that's a great question. And it may take more than 30 or 45 seconds to answer, but the simple answer is that I was born into a medical family. My father is a retired internist and gastroenterologist. In fact, over my right shoulder is the plaque from his office in New York City, on the bookshelf behind me in my office. And, I have a real sense of pride about the fact that my father, born into an immigrant family, became a physician and became one of the busiest internists in Lower Manhattan. He was a go-to physician for essentially, a substantial chunk of Lower Manhattan. I had a slightly different path and went into academic training, but have remained a very busy clinician at the Massachusetts General Hospital Heart Center. And so my research really merges the two worlds that I come from. I was born and raised to be a clinician, but I also happen to be a translational researcher. And because of that, it's given me a unique vantage point, I guess, to sort of understand where clinicians might better care for their patients. What are we missing with respect to recognizing disease and intervening in a more accurate way?
Wow, I love that, because that lines up with what we talk about all the time for doctors. And you'll notice we have 4 doctors behind us, but the reason we have that is because we say, and we echo this over the last couple of years especially, is it's no longer about being the best doctor in the world. It's about being the best doctor for the world, for your patients, and even smaller, for your local community. And I think that takes a lot of the pressure. It releases that pressure valve for physicians to be like, I don't need to be the best in the world. I just need to be the best for my community, for my world that I live and work in. So I'll let you go ahead and bring up your slides. And you have a presentation or a talk for all of our physicians listening that I think is going to be very, very helpful. Dr. Januzzi works with Mass General Hospital. He's also a Hutter Family Professor of Medicine at Harvard Medical School. And he's going to bring a lot of information, a lot of insights, and you can get this slide deck. We'll put it above and below in the links. But if you're listening to this, the audio version, go to conciergemedicinetoday.org or fourdoctorsforum.org. I'll let you go ahead and kick us off.
Super. Thanks very much. And, for the next 15 minutes, what I want to try to do is give a good background for how we have looked to improve the diagnostics and management of patients with suspected or even known coronary artery disease. Because ultimately, for us as clinicians, it's about understanding as much as we can about our patient and then targeting therapeutics as best as possible. And as I've already said, I'm the son of a clinician. I come from a medical family. My career has been dedicated to improvements in cardiovascular care. And I'm a biomarker guy, to simplify things from a research perspective. My career has been spent focusing on optimizing the understanding and application of blood tests. The challenge, of course, is that cardiovascular disease has a multifactorial set of reasons why it develops. And that goes for multiple different heart diseases. That's not just coronary disease, but we focused on coronary disease given that it is the #1 killer of men and women in the United States of America at this point. And what we elected to do, and this is leveraging the advances in both biomarker technology as well as data science, taking artificial intelligence, machine learning, and combining numerous data inputs through screens of multiple hundreds of biomarkers and clinical variables in order to better develop strategies for evaluating coronary artery disease, as I'll explain to you. And this was done in partnership with my team at the Massachusetts General Hospital, as well as some industry partners, in order to try to better manage our patients, and recognizing that cardiovascular disease is such an important cause of morbidity and mortality in our patients, and often has a long runway for its development, such that earlier recognition and earlier intervention would be expected to improve outcomes. And the difference between, for example, measuring high sensitivity CRP or measuring myeloperoxidase or some of these other markers that have been suggested as being useful for the evaluation of patients with suspected coronary disease. What we did was we actually approached this from what's called an inductive approach, which is we didn't start with the biomarker and then look and see how it performed to predict outcomes. What we did was we measured hundreds of markers and collected hundreds of clinical variables, and then looked at which ones independently predicted the endpoint that we're looking at, including the presence and severity of coronary disease. And we've been able to obviously take our findings and publish them, present them globally. And we've really tried to take the academic route with the approach and really have found through multiple cohorts that the findings that were originally developed at the Massachusetts General Hospital Heart Center have been widely applicable globally. Other cohorts, such as individuals that were enrolled in Hamburg, as well as here back in the United States in the Washington, D.C. region at Inova Fairfax. And so these are validated findings from the MGH and are now commercially available as a consequence with patents issued from the United States Patent Office. So what I'm going to talk about today, Michael, are two different blood tests that have been brought to the bedside. There are others that have been developed and are currently being brought forwards, but these are the two that I think at present have the greatest potential role for the management of our patients. There's one that's called CVE, or cardiovascular events. This is a biomarker panel that was developed to predict the 1-year risk of heart attack, stroke, or cardiovascular death, the so-called triple major adverse cardiovascular event, or triple MACE endpoint, that is so commonly used as an outcome measure in clinical trials of cardiovascular drugs. And that you can already jump forwards to how I will answer the question of how to use these tests, because the CVE panel, for example, was developed as a way to predict the very outcomes that drugs like cholesterol-lowering agents, diabetes drugs, antihypertensives have been validated against. The second panel is another really unique and interesting panel that we developed that has been refined to predict the presence of obstructive coronary artery disease, the CADhs panel. So let's start first with CVE. As I said, this is a biomarker panel whose role is to predict major adverse cardiovascular events. This is, as is stated on the slide, it's low cost, it's a blood test, so it's low risk, and it's highly accurate. And it consists of 4 different biomarkers, an N-terminal proBNP. Many of you might recognize that one. But then there are others that you might not recognize that were identified in this inductive machine learning screen as being predictive of cardiovascular events. Osteopontin, kidney injury molecule 1, or KIM1, and tissue inhibitor of metalloproteinase 1, or TIMP1. When we panel these markers together using a proprietary algorithm, the accuracy is really quite remarkable, essentially with very, very high sensitivity and specificity. The area under the curve, or the AUC, for the derivation was 0.79. For the validation, it was actually higher at 0.86. That's essentially saying 80 to 86%, 79 to 86% accurate, which is far, far better than stress testing, far, far better than other tests that we run like PSA, for example, for predicting things. And so this kind of discrimination can only really be developed when you use this machine learning kind of approach. So why do these proteins in CVE predict cardiac events? Well, we know that natriuretic peptides are a really good predictor of outcomes because they identify myocardial stress, right? The heart's releasing natriuretic peptides because of something that is causing either strain or stress on the heart muscle. KIM1 actually, although linked initially with the presence of kidney dysfunction, which independently is a predictor of cardiovascular events, KIM1 has actually been strongly associated subsequently with the presence of vascular inflammation. Osteopontin also is associated quite strongly with the development of calcific coronary artery and other vascular disease, including cerebrovascular disease. And TIMP1, for anyone that's a scholar of atherosclerosis development and decompensation, TIMP1 is associated with plaque instability and the risk for myocardial infarction. Now, what we do with CVE, as I said, is we panel it out in a score kind of fashion, and the derivation and validation are seen at the top of the slide. But when you want to look at how you might interpret this, you can cut it in any different number of ways, across a 10-point level, or you can just cut it low versus high. The bottom line is, depending on how many risk levels you use, you can develop an approach that gives you a strategy that can identify people with lower risk, moderate risk, and higher risk. And it's a continuous variable. So someone that is sitting at the lower end of moderate risk is nonetheless lower than someone who's at the lower risk than someone who's at the upper end of moderate. So it's important for clinicians to start thinking in a continuous manner, but in order to provide some clinical guidance, we want to make it as understandable and actionable for patients. My interpretation of the results is always low risk is better than any other level. Because if you look at, for example, the time to event analysis, those individuals that are found in the lowest risk categories have a very, very almost zero risk for adverse events, whereas those individuals that are found in intermediate or higher risk categories certainly do have a higher risk that diverges quite early. So you get both an early risk stratification that can clearly last all the way out to a year's follow-up. We've subsequently gone and validated these results in an external cohort, as I've already said, showing once again, really quite a remarkable performance. And we'll get to more about, well, what do you do? Let me jump back one slide. What do you do if you get someone who's in the red zone? Or what do you do if you've got somebody in the yellow zone? How do you manage these individual patients? Because ultimately, as a clinician, getting a blood test is easy. It's, as has been said, since last night was the opening night for the National Football League, it's the yards after the catch that matter almost more than anything for our patients. Once you make a finding, once you make a diagnosis or identify risk, what do you do next? Because measuring things is important, but following up on the result is also very important. And that speaks also to the other tests, because if you're going to be measuring something that is in part a predictor of plaque rupture, a predictor of myocardial infarction, what else might you be thinking about? And certainly this test, the CADhs test, is definitely something to consider. And I tend to recommend measuring both of them at the same time for that reason. The CADhs test, much like the CVE test, is inexpensive. It's, again, a blood test, so it's low risk. And it is really accurate for predicting the presence of underlying coronary artery disease. So this is the kind of test, when patients come asking for a calcium score or a CT angiogram or a stress test, a PET scan, whatever. This is where this test often would be, I think, a better choice for a number of reasons, not the least of which is it provides excellent sensitivity and specificity. It doesn't require radiation, and also does not require any other interpretation other than what the clinician who ordered the test can deliver. So how does this one work? Well, it again consists of proteins, but also clinical parameters. So when the test is ordered, there are a couple of boxes you need to check about the patient's past medical history. The proteins in this one are high sensitivity troponin, well known to everyone. But what's interesting is that people often think of troponins as heart attack markers, but it turns out that even among individuals who do not have a myocardial infarction, troponin may be elevated and associated with the presence of underlying coronary disease in the absence of an MI, even in ambulatory asymptomatic individuals. So that's a very important observation. The second point, the second marker rather, once again, is KIM1. I mentioned it earlier. KIM1 associated with kidney disease, which itself is a risk for CAD, but also a risk for vascular inflammation. And lastly, adiponectin. Adiponectin's a really interesting biomarker. It's a what's known as an adipokine, which is a cytokine that's associated with adipose tissue, right? And this cytokine, adiponectin, is associated with the ability to break down glucose and management of fatty acids. So it's often abnormal in individuals with diabetes, but maybe abnormal in folks without. And so when you combine these tests and clinical variables into a score, once again, we can appreciate the ability to both identify folks that have a very low risk for obstruction. And in this case, we selected an obstruction of 70% or greater, sort of very conventional, threshold for severe obstruction. However, I'll point out that across the scores that are generated, there's actually a linear association with the average coronary obstruction. So for those individuals that have a score of 4 or 5 considered high, they're up at the 70% or greater range. But folks with a score of 3 tend to have, on average, moderate coronary disease, and those with a score at 1 or 2 have much less obstruction, if not any at all. And so, again, advantages here, unlike a functional test like a stress test, or a calcium score, which both misses lipid-rich plaque and also doesn't tell you about the degree of obstruction. Depending on the score in the CADhs assay, you'll actually have a general framework for just how much athero may be present in your patient. And so these tests, both of them really, are well suited for evaluating individuals across a wide range of different venues: outpatient, inpatient, individuals with residual symptoms after COVID-19. We actually measure presently at the Massachusetts General Hospital Heart Center several biomarkers in our post-COVID-19 individuals, including troponins, natriuretic peptides, and others, which are included in these assays. There are other applications besides the physician office, including yourselves, the concierge physicians, for monitoring and evaluating both the worried well folks, but also individuals who have risk factors. I feel quite strongly that as we approach our patients, there should be a structured approach for the way that we deploy our diagnostics. And a simple blood test like this plays a very upstream role prior to thinking about reaching for nuclear imaging or cardiac CT, which, as I said, requires dye, it requires radiation, etc. So now the million-dollar question, of course, is, okay, I've measured MPO or galectin or whatever over the years, but the result comes back abnormal. What do I do with the results? And Michael, I'm looking forward to our discussion about this in more detail, but I guess what I would say is you can start seeing, based on how we calibrated these tests, to identify individuals that have actionable findings, together with linking up the outcome measures, for example, with the CVE assay, with the outcomes of clinical trials of various drugs that have been recently examined. Those folks with low scores with CVE, we're obviously going to always maintain prevention, but we want to think about the intensity of that prevention, including statins, as well as other therapeutics that might be used, blood pressure control, etc., the more conventional, lesser aggressive approach. Anyone with intermediate or higher scores, those are folks that, depending on the presence or absence of symptoms, we would tailor the therapy accordingly. For my patients with intermediate scores, I go high dose potent statin. If they've got hypertension, I begin to more intensively monitor them. I will refer them for physical therapy and rehab, for diet as well as exercise counseling. And furthermore, I link up the CADhs score. For my diabetic patients, I will initiate across the board SGLT2 inhibitors and GLP-1 receptor agonists. Again, I'll remind you that the endpoints in all of the trials for those two classes of diabetes drugs was triple MACE, which is the same endpoint that was what the HART CVE was developed against. And then for those with higher scores, particularly those with atypical symptoms, that's where I will reach for further testing. So it allows me to tailor the use of the higher intensity evaluations as much as is possible. Now, the other thing that gets asked is, well, can I get the individual biomarker scores? And you can. And that also might help for those that are biomarker weenies like me who understand these things to tailor based on the individual markers. Of course, for NT-proBNP, we've got a whole toolbox now at this point for how to manage elevated natriuretic peptides. But it turns out there are data looking at in randomized fashion the effects of drugs like ARBs on osteopontin, statins on TIMP1, as well as KIM1. Interestingly, there are some data now looking at SGLT2 inhibitors and KIM1 elevation. So we're rapidly coming forward with an even more individualized approach using the various markers that are present. Now, as far as the CADhs score is concerned, I mean, ultimately, it comes down to very similar management, right? I mean, if you know that a patient has a high risk for MI, stroke, or cardiovascular death as a consequence, or the presence of obstructive CAD, to a large extent, your management is going to be pretty much what I outlined earlier. I like to see my patients have lower scores because that's where conventional, non-invasive preventative measures are typically applied. The things that we should be doing anyway. But once we start narrowing down to the higher risk individuals, that's where the more intensive management, aiming for very low LDLs, less than 50, for example, use of PCSK9 inhibitors or other therapies, very directed, targeted at atherosclerosis would be utilized. So that's a sort of a high level summary over the last 20 minutes, 15, 20 minutes for how these tests were developed, what they look at, what sort of information you might be gaining from them. And, I'm happy maybe at this point, Michael, to take some questions. I'll stop sharing my slides if that's okay. And maybe we can talk a bit more.
Yeah, so we've had a few questions come in. The first question, I'll just jump right into this is our discussion portion of the interview here today. First question that's come in is, are these panels more accurate than coronary, artery, calcium scores? And what are the reasons I should use these multi-protein scored panels versus a coronary artery calcium score, which is less expensive? And then they gave an example here. A more accurate HART, H-A-R-T, is $199 per test. 2 tests for $328. Second is $129 if ordered at the first test, or calcium score is between 99 and 149. That question is throwing a lot at you.
Yeah, no, it's okay though, because I've already sort of addressed some of this. Calcium scoring is a great test. I mean, there's no question that particularly for, just like the heart blood test, if your CAC is 0, if you have a calcium score of 0, that's where the money is with calcium scoring. The problem with calcium scoring is that anything above 0, we're immediately in an ambiguous situation where we don't know whether there's obstructive coronary disease. B, we don't know if there's lipid-rich coronary disease. All we know is there's calcium. And that's a challenge, particularly when we're trying to decide on, among other things, what's the risk of my patient and what should I do medically. And for anyone that says, well, I already know what to do medically for patients that are at higher risk, I would challenge even my best colleagues at Mass General Hospital to take a step back with humility and look at how we are managing our patients. We are doing a good job. We're doing a better job at lipid lowering. It looks, there were recent statistics showing, for example, that 58% of individuals that were eligible for statins in the United States are now receiving them, which is a lot better than it was, say, 10 years ago. But that means 42% aren't receiving it, number one. Number two, it also means that the highest risk patients are very likely the ones that we're missing, right? And to the extent that we know that almost every therapy we give has an incremental benefit in the higher risk folks, but you need to know how to titrate these therapies. A CAC score isn't going to tell you your patient is at risk at high risk for a myocardial infarction in 1 year, nor is it going to tell you they've got lipid-rich plaque, nor is it going to tell you that they've got highly obstructive disease like these 2 blood tests do. So it allows me to make informed decisions about the need for lipid lowering, the intensity of lipid lowering, the need for other therapies like direct treatment for atherosclerosis or coronary ischemia, and whether or not I need to go to further testing. The use of CAC scoring, is helpful to maybe, reclassify people to a very low risk strata, but anything other than that, I'm not sure that there's a really good comparison here.
The next question that's come in is, are these panels accurate on diabetics?
Oh, great question. Really great question. So people with diabetes, obviously, right out of the gate have a high risk. And to the extent that we now have not one, but two classes of anti-diabetic therapies that can actually reduce cardiovascular events, this brings it even into sharper focus, So the American Diabetes Association is in fact in the process of evaluating their position on whether we should be screening our patients with diabetes utilizing some of the biomarkers that we have in our panels, natriuretic peptides and troponins in particular. And the reason why is patients with diabetes, even in the absence of manifest cardiovascular disease, frequently have underlying heart disease. It's well recognized. Diabetes is essentially an equivalent for the presence of cardiovascular disease. So we looked at this question utilizing these tests, and the answer is there's a remarkably powerful ability, in particular of the CVE assay, the cardiovascular events assay, for actually not only predicting adverse outcome in diabetes, but the risk is like 4 or 5 times higher if your CVE is elevated in a person with diabetes. So the answer in long form, I can shorten to absolutely yes. These tests work remarkably well in patients with diabetes, a population, quite honestly, that we should be focusing all efforts on with drugs like SGLT2 inhibitors and GLP-1 receptor agonists.
Wow. Our guest today is Dr. Januzzi. He's our speaker, and you're listening to Dr. Januzzi here at the Concierge Medicine Forum. We'll put links to this interview, to the slide deck, as well in the links above and below. If you have any questions about these tests, you can direct them to the contact information that's in the bio below and above. Number 3 question that's come in: are there any patients it should not be used? For instance, the chronic kidney failure patient population.
So the simple answer is no. We've looked at it across the entire range, of kidney function, for example, and we found that these tests work, very well in those patients. I will say, however, some practicality needs to be deployed when we use diagnostics. And in somebody with end-stage renal disease, the risk for heart disease is so astronomically high. Those patients really ought to be receiving the full court press in terms of preventative evaluation and management as possible. So, putting aside that very special population, there's really no kidney function level that makes these tests inaccurate.
Next question, and we're kind of rapid firing at you here. Recommendations for treatment plans based on the proteins or risk scores.
Yeah, I've already sort of gone through that, which is basically, when you've got somebody who's low risk, then you're in full out prevention mode. And it's really using what you already know about the patient, including conventional measures, to decide on how you want to manage them. It's the patients that are outside of the low risk zone where, I think it's just so critically important to put the full court press on for risk factor modification, lipids, sugars, blood pressure, tobacco, exercise, weight loss, alcohol use, all of the things that we have tools, but don't do a very good job of applying sometimes. It really sharpens the focus that, these are not the patients that you should be relaxed with. And then in the higher risk patients, regardless of the assay used, whether it's CVE or CAD, there you've got a patient who's at very high risk for a cardiovascular event, presumably from a vascular cause. And so, if they're symptomatic, further steps to try to understand whether they need an invasive evaluation. So that's a more of a procedural step. But as far as the medical management, again, it's the full court press of medical therapy. So it's helping us to get more towards an individualized, personalized approach for the care of our patients and prevention of the number one killer of men and women in the United States of America.
Well, let's back up for a moment and then get a wide angle on this. Uh, there's a lot of enthusiasm typically when physicians go to a conference or they hear about read about something in a medical journal. And it's, Friday afternoon when they're hearing it right from, the speaker on stage, it's like, this is going to change everything for me when I go back home. And then they get back home and it's Tuesday, Wednesday, and they get followed up with, or they revisit something, they revisit the topic, and they're on an island all by themselves. They're back into the routine and they're as busy as they were, but kind of that stuff is still in the background. But, the enthusiasm on Friday has waned. And now it's like, we follow up or someone follows up about this and says, hey, I think you really should consider putting this into the practice, into the exam room. No. That's not how we do things here. And that was great on Friday afternoon at a conference, but we don't do that. And I find that so many of the physicians we talk to, especially in concierge medicine, are so frustrated with that aspect of enthusiasm, where it's like, we talk a big game about being innovative and being that healthcare is moving so fast, but yet come Tuesday or Wednesday in traditional plan reimbursed practices, we find that there's this pushback, there's a tension that exists.
Yes, agreed. Yeah, no, I completely agree, which is why at their core, both of these blood tests, although yes, it's Friday afternoon and we love talking about the science behind it and the biomarkers and the artificial intelligence that was used to create the algorithms, et cetera, at their core, both of these blood tests are telling us something that we deal with every single day in the office, right? And when a patient comes to me in the office and says, I'm worried that my father died of a heart attack at age 50 and I'm 65 years old, and I'm worried about my cardiovascular risk factors. My LDL is 90. Should it be lower? My blood glucose is fine, but my A1C is 5.7. Should it be lower? Those are patients that are very common in our practice because, among concierge physicians, among folks like myself who have a very concierge-like practice at the IMGH Heart Center, we have patients that are very well informed. They know where to find information about lowering their risk factors. But the question is that good enough? Are we delivering the kind of care that our patients, the individual patients sitting in front of us, should be receiving? We know that getting LDL under 100 is good. We also know that getting LDL under 70 for high-risk patients is better. We also know that in the Improve It study, getting LDLs under 50 for the highest risk patients, the really highest risk patients, is even better. We also know it's safe. We know that therapies like GLP-1 receptor agonists reduce atherothrombotic complications, even in people without diabetes. So ultimately, when it comes to our patient who's sitting in front of us, who is concerned about their individual picture, that's where tests like this can be really useful. Because at their core, it's kind of boring, right? I mean, one test tells you got coronary disease, one test tells you have a risk for an atherothrombotic complication. Simple answer. There's not a lot of nuance to the results that these tests tell us. But in and of itself, those results give us very actionable information. And no, my friends, in the medical world, we do not all lower our patients to LDLs under 50. We do not have all our patients at blood pressures of 130/80. The simple truth is a lot of our patients are resistant to that kind of aggressive treatment, but if given a reason to accept it, many more would be expected to accept it.
Amen. And that goes along with what we echo around here quite a bit, is it's no longer about being the best doctor in the world. It's about being the best doctor for the world and for your patients. And 5 words from a doctor mean more than 50 words about you. And if you're expressing and telling them about this, Dr. Todd Feynman is a a wonderful speaker around here, and he always says, "Show me the evidence." Because we put more research into what car we're going to buy or what refrigerator we're going to put into, but we don't always look at the evidence behind this. And certainly Dr. Januzzi has come today and shown you the evidence about this. And now we're moving into the simple, portable, and memorable portion of this. We have 3 more questions for you.
Okay.
So this is what I want you, these are questions more or less that the physicians will remember and take away with them of like, oh yeah, I need to do this. So first question is, how do these panels differ from what I can get from other risk tests or chorus CAD or gene expression tests?
Yeah, it's a good question. The market is there, right? And, each of these different tests, for example, chorus, is to identify obstructive CAD, much like the HART CVE score will. Part of the challenge with each of these is you have to look at what they're indicated for, which patients you can and cannot measure them in. So chorus, for example, well, first of all, it's less accurate. That's number one than the HART CADhs score. But then on top of that, you can't measure it in certain patient groups, including patients with diabetes and patients with kidney disease. So it's important to emphasize that there are some blind spots with some of the other assays on the market. But, the way I look at it is the fact that there are other options tells you this is a viable and growing field. And that's really ultimately, for me as a biomarker guy, but also as a clinician, encouraging, because we are moving towards a more biologically driven, individualized approach for evaluating our patients.
Thank you. Our second to last question is how, and I can't wait to ask you the last question, by the way. It's a surprise one, and I ask it of every guest, but you're going to be like, wow, that's an easy one.
Can't wait.
But the second one is, how can patients get these tests?
Well, I mean, that one, I'm not a business person. They can be ordered from Prevencio, the company that makes them, and there's an order form. And the nice thing, especially for a concierge set of patients, the blood can actually be even drawn at home. They have a service that can go into the home and draw them. I've had patients, for example, I have a practice similar to yours, Michael, where I have patients that live in Florida but see me in Boston, and I've been able to get blood drawn down there, and the results sent to me. So it's available. The company markets it.
Wow. Well, and we'll put links to that above and below, as well as the slide deck and the evidence that you have seen today. Because again, as patients, you know this as well as anybody, and so the doctors listening, is patients come in well equipped, much more equipped with knowledge and insights. Yeah, I mean, it might be wrong. They might be relying on Dr. Google, but for the most part, maybe they've been to tons of other specialists. Like my daughter my daughter and my wife and I have been to tons of specialists lately and gotten all kinds of contradicting information. But you've shown us the evidence, and the evidence is clear. And we're going to put links to Dr. Januzzi's slide deck, links to where you can go and get more information, where you can look at ordering these tests as well. But even if you're looking at geeking out and want to learn more, we'll put that information in the slides below. Our last and final question for Dr. Januzzi is, if you were to hang up your spurs today and say, you know what, I'm done, I've ran the race, I've finished it, and that last patient is why I did this, it's why I do this. Give us an example of where this really hit home for you recently.
I mean, gosh, as a cardiologist, there are a lot of really important examples of why we do what we do, right? And it ranges from the person who comes to the office worried about their risk, who unfortunately has that event that they were worried about, and then there is the patient that you take care of acutely ill and carry through their illness through a difficult hospitalization and send them home. And that day that you see them in the office and follow up, feeling well, looking great, those are all the things that for me matter so very much. I mean, I'm not I'm not in this space to be a researcher. I'm in this space to take care of patients, and it's nice that I can do both. And those experiences as a clinician are what make this job worthwhile. And it's hard to imagine hanging up my spurs, but someday it'll have to happen. And what I'll take away from my job, after the many years of working in the MGH Heart Center, is the combination of those personal experiences with patients that were so meaningful, together with the fact that I feel like maybe we may just have made a difference for them, with respect to the research that we've done.
And that is a great story. And you said something very early on. It is the yards after the catch that matter most. And I think that that's something that we should all be putting on our walls, because it's so applicable to healthcare, especially concierge physicians and any physician really, because it is how many times have we, as patients, I always say, I'm not a physician, but I am a patient, and I know what it's like to sit on the other side of you. And so often we as patients are given these acronyms, these long digits, let's order this, and then the physician leaves the room and we're left in this wake of like, what just happened?
Right.
And it is the yards after that, it is the communication after that, it is the touching base after that, that really matters most. And so we're glad to hear you echo that from your lane, from your path, and we're so grateful that you've come to share this with our physicians today and with those listening. And I truly think that this is going to change their practice, one patient at a time, for their foreseeable future. Our guest today has been Dr. James Januzzi. I will put the links above and below to a slide deck, as well as some contact information on where to learn more about this. And Dr. Januzzi, thank you for being our guest today.
Thanks so much, Michael. It's been great to be here. I really appreciate the invitation.
Let the notes flow, a symphony. Now I can say things differently.
It's a really great thing. You've got an idea, you've got a medical practice, you've got patients who come in and out, but that thing that you want to do called concierge medicine, there's a learning curve to it. Do you want to accept insurance? Do you want to participate in Medicare? Do you want to do a hybrid practice? What's your staff going to look like? Are you going to incorporate different tests inside of the office? And if you're interested in me speaking a little bit of truth to you, and sometimes it's not as easy as we think. We want somebody to just say, oh yeah, you can do this right away. It'll take you like a week. Sometimes we don't really want to hear that. There's the learning curve to this. And the speakers that you're going to hear, the presentations and courses that you have access to within this community are here designed especially for you. Please go check them out.